Hi, and welcome everyone to this seminar, which is on the SAMIT 75 tool. And to some degree, the seminar is no more than saying, we got this tool, we think it's great, please use it, play with it, because there's huge knowledge and intelligence for your local hospital, your local service there. Next slide, please, Darren. That's the schedule of the day. So it's mostly from us, the design team who've created the tool, just describing it, and then with some questions and answers at the end. The Q&As are by text. It's not a verbal thing, but if you can post them, we will answer what we have time to answer, but I will answer by email any queries you have. And right at the end, there's a slide to how to access the tool if any of you still are struggling with that. Now, next slide, please, Darren. When we wrote the National Report for GIRFT in Frailty and Geriatrics, one of the recommendations, which was largely ignored, probably because it was in the too difficult box, was to come up with data, local data for your hospital, and to create a frailty dashboard. And I think, it is difficult, and what we've come up with here with SAMIT 75 is something that approximates to or is usable as a frailty dashboard for your hospital. But it is limited, it is largely hospital-based data. But today's exercise is to explain what it is and how to use it. And I'm assuming most of the audience is aware of certain things to do with frailty. Next slide, please, Darren. But just so GIRFT gets very interested in unwarranted variation. So if you didn't know, the left-hand chart is as patients become more frail, this is all NHS England, length of stay goes up. No surprises there. The more surprising thing on the right there is the variation between hospitals. So every one of those is a hospital. On average, frailty from this data set increased length of stay by 8 days, but with huge variation between hospitals. And that's the challenge. Are some hospitals better at it? Why? And the SAMIT 75, which gives you benchmarking data, is a way into this. But note, next slide, please, Darren, where we are now is not a static picture. Every year for the foreseeable future, there'll be 2.5% more older persons over 80s in the UK. And if Chris Green, the ESIST analyst, if we just pro-rata that in 25 years' time, if nothing changes, we'll need to double the size of the hospital estate. So one of the things of using data is we also have to future-proof the system. But this is just an example. We've all lived through the queuing issue of the modern NHS. But this is just if you are over 75. Before COVID, 10% of patients waited more than 12 hours for admission. Currently, it's 35%, 3.5 times greater, and peaked at 60%. So we're all familiar with the strains on the system at the moment, and this is manifested in the queuing we're seeing now. So I'll now hand over to Darren, who's going to give you an official history of the SAMIT family of tools, of which this is the most recent. Darren.
Thank you, Adrian. So my name's Darren Best. I'm the Workstream Delivery Manager for GIRFT UEC. Before the main event, I'm going to quickly go through a number of products within the GIRFT portfolio that we think could possibly help you with those who work at the front or near to the front door of acute trusts. So if you can go on to the next slide, please, Sophie. So in front of you, we've got the 3 products within the GIRFT portfolio. So as you can see straight away, there is a similarity between all 3 platforms. That allows you to walk and talk through any of the platforms with ease. So on the left-hand side there, we've got the SEDIT which is a platform that's showing the emergency department of your trust. It provides you with an overview of the good, the bad, and the ugly. In the middle, you've got the SAMIT, which is the acute medicine variant. And then on the right-hand side, obviously, we're talking about the SAMIT 75 today, but that provides you with an overview of the frailty in older people aspect of your trust. There's two ways of gaining access to these platforms. The first one is through NHS applications A to Z. If you scroll all the way down to S, you'll find both the SAMIT and the SEDIT there. So if you apply on there, you gain access within 24 hours. Just to note, for the SAMIT, when you apply for the SAMIT, you'll be given access to SAMIT 75 by default. If you are a user of Model Hospital, then you can also gain access through that facility as well. So Sophie, do you want to go on to the next slide, please? So in order to understand how these platforms are coming to being, I just wanted to very quickly give you a brief overview of the background to them. So way back in 2017, the GIRFT Emergency Medicine project, led by the late Cliff Mann and Chris Moulton, together with Andrew and myself, we used to undertake sessions around the country looking at EDs. With us, we used to take a data pack which had a fantastic amount of data within them. The only problem was that they were so large that we had to try and find some of those key metrics to present back to the sites. So one of the key learning points from us was to how do we tease out that information to provide a better overview for some of the sites so that they better understood their departments. So having the GIRFT data in the first instance, kindly brought out by Andrew, allowed us to sense check some of the items that we discussed during those sessions, as well as bringing together some contextual information to provide sites with how their particular departments were running. So that led to the SEDIT being released in 2020. We're currently now on to version 5 of that particular platform. But the same concept has then ran into the SAMIT with the acute medicine variant, which was released in 2023. And now, obviously, we're talking about the SAMIT 75, which was released earlier this year in 2024. So if you go on to the next slide, please. There's two other variants that we're dealing with at the moment. So there's a Northern Ireland SEDIT, which was released in 2023. And we have released the Wales version in 2024. Cognizant that this is a session on SAMIT 75, I'm going to hand over back to Adrian to describe the SAMIT 75 in greater detail.
Thank you, Darren. And next slide, please. So the first thing, Darren's already mentioned the model hospital, and that overlaps very much with the SAMIT 75, but it has slight differences. First of all, it tends to be much behind, so it's several months behind, about 6 months on average. And secondly, and this is very important for you working in hospital sites, is it's a trust-wide platform, while the SAMIT 75 and all the SEDIT SAMITs work at a place, a hospital level, which I think is a much more important unit. The other differences between the two tools is both use identification of frailty using administrative data. The global frailty scale is what we use for the model hospital. Hospital frailty risk score is what we use in the SAMIT 75. Next slide, please. So here it is, after much trailing, this is what you see, and it's a monthly refresh. So we're now showing August, so it's about 6 weeks behind. As I say, it's a mixture of information. Some is grouped around over 75-year-old patients, and generally this is about admissions in the emergency medical pathway. And the third thing is all these tools give shine a light, show a picture, but there are issues. The particular issue that affects SAMIT 75, now this is hospital data, but for some integrated trusts, their hospital data includes community beds and other community data, and it looks very different from standalone acute trusts. So there's always an interpretation you need to put on benchmarking, and equally within the tool there is a whole bunch of possibilities looking at time series. So you need to have a sort of look at the benchmark. Everyone is interested in that, of course, but also look at the time series changes for the key metrics. But this is the overall tool, and I'm just going to simply walk you through the main highlights. As I said at the beginning, the most important thing is that you get access to it and you get familiar with it and you start using it, and much interest will come with that. Next slide, please. So this is at the top of the banner, and I'll just pick out a few things. This is the hospitals are anonymized here. So the first thing is the activity. How many patients over 75 are admitted? Not frail patients, to give you a sense of activity. Along in the purple bit of the column is, and this is two things I look for whenever I look at a hospital, is the proportion of your over 65-year-old patients who have moderate or severe frailty. This is judged by the hospital frailty risk score. So volume and the degree of frailty. On the far right there in the orange is the ranking score, which I'll come back to, but how you are judged against your peers is one thing. And then on the bottom, now this is why we end up often double showing data, is that one of the variables in terms of how frailty is identified, it's in the end linked to the quality and effectiveness of coding. So there are two coding metrics there. One is just the numbers of diagnoses captured, and secondly is the proportion of patients where a basket of dementia or delirium diagnoses are captured. But if you ain't got great coding, then you will tend to therefore undercapture frailty, and that's where there needs to be a combination. If you've got very poor coding, look at the over 75 data as well as the frailty data. Next slide, please. If we come on now to a series of graphs, and this includes two really core metrics. So the first graph on the left there is you're admitted as a medical emergency. You're frail, defined from administrative data, over 65. What's the chances of being discharged in under 3 days? And this is absolutely fundamental. This hospital is the dark blue line, and the comparators are England and regional average. And you see for this hospital, the figure is up to 40%. This is about as high as we see in England, and this is a hospital that probably doesn't have great flow problems. Hospitals that do have flow problems, this figure is down at under 20%, sometimes as low as 10%. So a 3- to 4-fold variation in this key metric of the effectiveness of acute frailty response. But note also it's time series this, so see the change in that trust. Is this a coding artifact, or have they done something that's shifted that? If I can move along now to the frail admissions over 65, and putting these two together with early discharge is really the sort of central insight into how flow is working in the hospital. So this is frail over 65. What's the chances of staying more than 21 days? And in this hospital, so this is going to work pretty well, that rate is low, the early discharge rate is high. But more importantly, and this has become one of our key metrics, is it's not the rate of discharge, but the bed utilization. So in other words, a combination of length of stay for the more than 21-day length of stay frail patients. So bed use. So the metric is the proportion of total beds that are used by patients, frail patients staying more than 21 days. And of note, if you wonder why the NHS is under such pressure, with the demographic pressure I mentioned already, note the average for that figure is just under 60%. So that is where most of, if you like, the bed utilization is. For patients, it's treating, some would say, warehousing patients with relatively long length of stay. And as I go around the country, the basic building blocks of an effective frailty service are more noted by their absence: recognition of patients with the clinical frailty scale, management of delirium, prevention of deconditioning, and so on. The quadrant chart is the next along, and I'll leave Andrew to talk about that. But just to note, this particular trust has got the quadrant in the top right, which is the most favourable, which means you've got good flow and in control of demand. Next slide, please. Now, then at the bottom are the four headlines color-coded. And what we use is a color coding system of red, orange, grey, and green. And that's the various quartiles, with red for whatever metric it is being the less favourable, where you don't want to be. And again, these are all mixed up. There's a whole melange of hospitals beside this. This is just to give you an idea of the data. In the other tools, we have demand, capacity, flow, and outcomes, and we don't have a capacity metric for frailty. The reason for SAMIT 75 plus, the reason being is capacity is not defined consistently between hospitals. What is a bed for geriatric medicine? What is a bed for frailty? So it remains, so the capacity is omitted. So here we have the demand metric. And what are the sort of things I look for? I mean, it's self-evident what you're seeing, but the proportion of your catchment area, catchment population that's admitted to hospital that's over 75, that ranges from about 55% to 35%. So immediately, if I'm going to a hospital where the answer is 55%, I make sure the senior leadership is well aware that frailty care is a central business for their trust. So we look at acute admissions over 75 and the average frailty score using the hospital frailty risk score, conversion rate, and so on and so forth. It's all relatively standard stuff. If we go on to the next slide, please. And this is grouped on the flow outcomes. So what we're looking at, but this is an example where we've got a doubler. So in other words, we're looking at that key flow metric of discharge in less than 3 days, but one of them is for frail patients and the other is for patients less than 75, same basic measure. And the reason for that is if your coding's rubbish, look at the over 75s. But to make that, there's a couple of these where we've put into just so for some hospitals, the data may be more interpretable one versus the other. 0 length of stay and 6-hour delays are also featured here. This hospital is all green, so all in the lower and favourable quartile. But just to note one thing that's so important. Why is every hospital in crisis every Monday? It's because patients aren't discharged at the weekend. This metric here, the average in the NHS is discharge on Saturday and Sunday rate is half that of Monday to Friday. And this is a metric here that gives that rate for your hospital. So broadly, it's the ratio between weekdays divided by the average of Saturday and Sunday. So of which 2 is about the average. So there's an interrogation of weekend discharge. Next slide, please. And then the final banner is outcomes, and this includes a bunch of metrics to do with, that are linked broadly to repeat admission, readmission. So we've got standard 30-day readmissions doubling between frailty and over 75. We've got bed utilization by multiple admissions in the previous year. We've got right at the bottom there readmission following a short stay admission in the first 14 days, because one of the issues is what can systems do to prevent repeat admissions, particularly after short stay. But also, and this is a really central metric for those of you concerned with hospital flow, we've got the 12-hour delay. As I said, the current average in the NHS is 35% of older patients are waiting more than 12 hours for a bed. And beyond the 12-hour delay is then the time beyond 12 hours that is the average wait. And there are several hospitals in England where that average is well over 24 hours. So the norm, the average experience is patients waiting more than 24 hours for a bed. And this is something when I travel around hospitals and see patients in corridors, mostly frail, mostly with delirium, this is a product of this data. Just to note, there is a couple of end-of-life care metrics. There's crude mortality, but also the one below the bottom is bed days in the last 90 days of life as a end-of-life care metric. I should have said at the beginning, if you sign on to SAMIT and SAMIT 75, you will generally just get your own trust, your own hospital, unless you have a national role. But for those who are working, I know the Southwest and the Midlands are starting frailty collaboratives. Working out an information sharing agreement would make a lot of sense to me. But at the moment, if you're applying from a trust, you just get single site. Now, next slide, please, and probably the last one. Then if you take these banners, and this is the clever and exciting bit, so you click on the flow, and what you get is all those 10 metrics with your value, the English mean and upper and lower quartile and median. But more interestingly, you get, as well as which quartile you're in, you get the box and whiskers chart as to where you are within that quartile, because you may be in the lowest or highest quartile, but exactly where you are within that. So you can identify, are you actually in the top or bottom decile within this? And then on the far right, and if you go to the bottom, you click on the metric and you will see there in red, that's a hospital that's comfortably in the red zone, but not extremely red. But more relevantly, on the right there, for each of these metrics, every metric in SAMIT 75, you get that time series graph that goes back, I think, to 2019, so about 5 years. So again, for any of you involved with improvement work in trusts, it's, yes, the benchmark is important, but it's the time series is also important. And you get that for every single metric. So if you want to look at your 12-hour delays or your 30-day readmission or whatever, you can see that displayed very well here. Next slide, which is, I think, the final slide, for me at least. And finally, we have chosen 3 of the metrics and put them together, so you end up in a ranking order of roughly the 165 trusts in the NHS. But behind this is extraordinary variation in some of these metrics between the highest and lowest performers. But the 3 we're using for the Jerry ranking is the ones I've talked about already: discharge less than 3 days, frailty bed use for length of stay more than 21 days, and then we're using bed utilization by the repeat 3 or more admissions in the year, so a sort of readmission metric. So those are charted. You see that's over the last 3 or 4 years, and then this is refreshed every month. So it is a little bit up and down, but I think the value is then you can notice your change. But this Jerry ranking is published every month, and you can track where you are. As I say, it's only part of the story. For frailty, some hospitals are systematically different in terms of their community bed profile, length of stay, for example, will look different. But it's something that certainly the differences between the best and the worst for any of these metrics is so colossal. I think there's great learning opportunities for those either at either extreme within that. So that's just an introduction to the tool. Do look at it, look at the charts, put the charts on the walls, focus your improvement efforts on that. Now, I'm just going to hand over now to Andrew, who's the analyst who's been central to this whole agenda, all the tools you've talked about. Andrew's been at the heart of this, and there's some sort of data nuances that I think are worth exploring, although we can't cover everything today. It's just to tempt you with some of the idiosyncrasies or issues of the tool. So over to Andrew.
Thank you very much, Adrian. Good afternoon. My name's Andrew Bozeman, and as Adrian said, I'm the principal analyst within GIRFT UEC, and have been around since about 2018, and as Darren described, developing the SEDIT for emergency medicine to start with, the SAMIT for acute medicine, and then now the SAMIT 75 for geriatric medicine. I'm just going to take you through a little bit of background in terms of what underpins the philosophy behind the different indicator tables. We'll talk a little bit about data quality, the quadrant chart, and then I've just got some final thoughts in terms of that growth in terms of elderly patients over time, which the NHS needs to address. So next slide, please. So for those of you not familiar with GIRFT, the underlying principle is it's a data-driven, clinically led program, and what we're trying to do is use that to identify unwarranted clinical variation. Now, so that's a very close partnership between the clinical leads for the different topics and myself in terms of analytics. And as Darren said earlier, we must have developed 200 metrics for each area, and then we've narrowed it down because it's impossible to sort of understand what's happening across all of the metrics. We needed something which was simpler on one page, was intuitive, and people could understand very quickly. So we described the SEDIT, the SAMIT 75 as not another dashboard. There are lots of operational time series data sets and tables that show weekly and daily data. It's not trying to do that. It's a strategic tool that can be used to diagnose why things are happening in your particular department or service. It's not particularly looking at the what in terms of is happening. Now, it does set out some of the what's, but it's more strategically in terms of it tries to point you as to what is causing the issue, and therefore your solution to that can then better focus on solutions to improve the services. As I say, it's a limited number of key metrics. We've tried our best to apply the less is more, and more would actually be less, and keeping it as simple as possible. The other thing is that we don't include any targets in there. So we set out how every site in the country performs against all of the other sites in the country in terms of which quartile a particular site is in for each metric. Now, we've provided a value judgment in terms of whether high is good or bad for a particular metric. And as I say, if you are in the worst quartile, you will be red. If you're in the best quartile, you will be green. But essentially, the SEDIT is not trying to be a detailed tool. There's the line there that it's better to be broadly right rather than specifically wrong, and you won't see any SPC charts in there. A lot of it is done visually and looking at direction of travel. But what we're trying to see between sites is whether someone is performing high or low, or good or poor. It's not whether it's to sort of 2 decimal places. The other key philosophy behind the SAMIT 75, or indeed any of the tools, is that there's no single metric will actually tell you what's going on. It's about building up a story from a number of metrics, either within a particular tool, for example, SAMIT 75, or indeed correlating a number of metrics between all 3 tools. And actually, we feel it's really important that rather than just looking at the SAMIT 75, to build up a picture of the whole UEC service, particularly the acute based element, you need to have a look at the SEDIT, the SAMIT, and the SAMIT 75. And indeed, we produce other summaries at a higher level that set out the GEMI score, the GAMI, and the GERI score, which are the key metrics underpinning the indices of patient flow. The other thing to say is that this is your data. The vast majority of it comes from published data sources, either within the NHS or indeed online. And what we are doing is essentially collating it into something that's sensible, holding up a mirror, and hopefully you can then see your service. As Adrian said, it's about 1 month behind, so we are currently showing August data in the SEDIT, SAMIT 75. And the other thing is, it does require your local knowledge to be able to interpret it. So, for example, there are lots of different ways that medicine is set up. There are lots of different ways in which the activity that is undertaken is recorded, and there is a lot of variation in the quality of the data that is actually recorded. So we're using the SAMIT at a relatively high level, but it does require that local knowledge. So if, for example, your site records SDEC as a type 5 ECDS, you will have different scores to another site that records its SDEC 0-day activity as a non-elective admission. What we've tried to do is build the SEDIT so that data quality is not the limiting factor. And that you can then look between a number of metrics and still be able to build up a robust picture as to what's going on. I'm going to come back to the domains. Adrian described them earlier, but I've got something that sort of sets out the domains and the scoring that works for the SAMIT 75. And I'll also show how that then feeds into the quadrant chart. So the last couple of things is that the SEDIT has been either the first or second in the country in terms of dashboards used, and the SAMIT and the SAMIT 75 are always in the top 10 in terms of dashboards that are used to support analysis of sites. As part of that, I think it was because when we built these tools, the intended audience were the hospitals themselves, to help them build up an understanding of what's happening within their hospital. And as I said earlier, it helps them to start the transformation to improve quality and patient care. Next slide, please. So we spoke earlier in terms of the domains. We sometimes describe that as the engine room of the SAMIT, and that's because we have a number of metrics which are scored. So there are 5 metrics within each domain which are scored broadly. If you are in the worst quartile and red, you will get a score of -2, and if you're in the best quartile of green, you will get a +2. And if you just see above the outcome tab on the top right there, you can see I put the little scores in terms of -2, -1, +1, +2. You then add up the scores on the doors for each domain, and you will see after demand there in brackets it says 4, and after flow it says -3, and outcomes it says -3. And that's really important in terms of those are the scores that drive the quadrant chart. So the demand metric, which is essentially trying to set out what it feels like from a hospital perspective, i.e. what is the case mix of patients coming through the door, and then the flow and outcomes, you add up those two scores together to get at your y-axis or your y-coordinate on the quadrant chart, which then sets out what it feels like from a patient's experience. Now, I'm not going to go through all of those individual metrics, but what I wanted to do was just log which metrics were scored within each of the domains. So next slide, please. This is the quadrant chart, and it was one of the 4 charts that Adrian described earlier. And what we can see here is you've got demand on the x-axis and flow and outcomes on the y-axis. And as I say, it takes the net scores from the different domains to calculate what those are. But it means something being in each quadrant. So if you're in quadrant 1, you can see that you are above the line in the middle. So you're in a positive position for flow and outcomes, and you're to the right of the central line, which means that you're in a positive position for demand. So what that means is, from the scored metrics that we've got, that there isn't a particular issue in terms of the demand coming through the door, and that the site is also then able to deliver good flow and outcomes to patients. As we move counterclockwise, we're now to the left of the x-axis of the demand line, so we're in a negative position. So now there is now an issue with the demand in terms of case mix of patients coming through the door, but these sites are still able to deliver good flow and outcomes to patients. And arguably those are the sites that we need to learn from in terms of how are they doing that, given the case mix that's coming through the door. As we move further counterclockwise into quadrant 3, we're now in a negative position for both the demand and flow and outcomes, and that's all arguably a balancing position. So there is now an issue in terms of the case mix coming through the door, and there is then a knock-on effect in terms of the ability to be able to deliver good flow and outcomes. And quadrant 4 is a bit of an anomaly, because we're now back on the right hand side in the x-axis in a positive position. So there's no apparent issue in terms of the case mix of patients coming through the door. However, there is still a knock-on effect in terms of delivering poor flow and outcomes to patients. Next slide, please. I just wanted to sort of highlight some of the issues around the data sources and data quality. As I've said earlier, that there's lots of variation in terms of how elderly services are set up operationally. There's different ways in the way that the data is recorded, and there's also different quality in the way that the data is recorded. But we're trying to design a tool here that will fit all 180 odd acute hospitals in the country, and also then be able to provide meaningful benchmarking data. The line at the top is sort of saying the relationship between the SAMIT and the SAMIT 75, in so much that we are focusing on those acute medical admissions, similar that the SAMIT does, but the SAMIT does it for adults, whereas the SAMIT 75 is focusing and looking through the lens of older and/or frail patients. So in terms of the sources, as I said, it's your data. The clinical data in terms of ED and admitted patient care data is from SUS, published SUS, and the frailty is from the Hospital Frailty Risk Score, which uses 100 or so ICD-10 codes. So it's therefore reliant on the quality of the coding that goes into that, but it looks over the last 2 years of admissions. So this was a paper published by Simon Conroy et al. That defined HFRS, and we've been using that in the SAMIT 75. Non-clinical data comes from a number of published sources. The catchment population, it's difficult to identify the catchment population of a hospital, but what we do is what's known as proportional flows methodology, which looks at where all elderly patients came from over a year. We know where they came from in terms of their postcode and LSOA, and therefore we can understand what proportion of patients came from which LSOA, and then we know the population of each LSOA. So we can proxy what the population is. But essentially what we're trying to do when we match that against activity is say, if you're above the line, it means that there is more activity than you would expect from your population. If you're below the line, then there's fewer patients, and that catchable population is over 75s. CQC, SHIMI, litigation, and then you've got the national training survey there. In terms of data quality, when we talk about medicine, we actually talk about a subset of medical specialties. So we're only looking at 18 key treatment function codes, and I've put a little table in there that sets them out. And what that's doing is saying that these are the main specialties that medical patients who are elderly would come in under, rather than looking at every very specialist service that exists. We also talk about, we've got older patients aged 75 and above, and then we've got frail. The reason that we choose frail at 65 plus is that is where the HFRS is scored at 65 plus, and we're also aligning that with the new CFS in terms of clinical frailty scale, scoring that and the CQUIN in ED that also targets patients aged 65 and above. But when we talk about frailty in the SAMIT 75, we are identifying those patients who have been scored as moderate or severe frailty, as per the scoring in the HFRS. In terms of care homes, again, there is some variation nationally in terms of how coding for patients coming from a care home, or whether it's usual place of residence and then discharged to a care home. So just a little bit of keeping an eye on those metrics in terms of validating it from your own perspective in terms of your hospitals. We also use the acuity index. This also appears on the SEDIT. The acuity index is trying to look at the acuity of older patients coming into an ED. And the acuity index is a fairly simple, crude proxy of the number of majors and rhesus patients divided by the number of minors patients. And the last thing there is SDEC, and as I said earlier, there's multiple ways in which SDEC is recorded, and you just need to be aware of that when you're interpreting your data. And the last thing about length of stay, we found some sites who have integrated acute community, and we are finding that community length of stay is appearing in the data. So next slide, please. I'm not going to dwell on this particularly, but I just wanted to leave you with a link. We published a paper that demonstrated the statistical association between different elements of case mix and outcomes. And what we found was that frailty is the largest driver of outcomes, and actually things like age deprivation have an impact, but it's a much lower impact. And so what we've been able to do from that is be able to aggregate up a number of case mix indicators into the case mix index. So we can then show the overall case mix of a patient aggregated up to a hospital, but we can then also derive what the predicted length of stay is for that hospital given its case mix of patients. Next slide, please. So just in terms of final thoughts, we are always keen to evolve the SEDIT SAMIT 75, and as Darren said, we're on version 5 of the SEDIT. So welcome any feedback if people have got ideas as to how we could better reflect elderly services. Obviously, the CFS is the CQUIN for this year, and that will support the analysis of frailty pathways to acute frailty teams. But we are also looking to try and develop the whole SEDIT so that we can look at the pre-hospital environment and also then the downstream environment in terms of virtual wards, criteria to reside, community data sets, ambulance data sets. And the last thing to say is, as Adrian said, that there is going to be a growth in older patients. It is becoming increasingly the driver of acute medicine, but I've done a number of clinical utilisation reviews and always found a large proportion of older patients that never met the eligibility for an acute admission, but had to be admitted because alternatives were not in place for those patients. But by admitting them, we are then subjecting them to increased risks of deconditioning and infections, and impact then on downstream care packages. So we are looking to develop our analytics to be able to understand the whole UEC pathway for older patients more, to then be able to support also the prevention of avoidable admissions. And the last thing I would say is that GIRFT also undertakes a tool called FrailTED, which does a scenario-based audit of the availability of services that would prevent both attendance at the ED but also admission. And it's a system-wide approach that helps to develop a baseline in terms of your out-of-hospital care to support elderly patients and prevent those inappropriate admissions. Next slide, please. And that's me handing back to Adrian, I believe.
Thank you so much, Andrew. If we just show the next slide, please, because that's got, oh, it's gone, data on how to access the tool, but it'll be in the slide set that is sent to you. And as Andrew said, is we need the, there we are, it's getting decent system data is the challenge, but we're still in that level of system data is often either unavailable or low quality. But at GIRFT, we've had some really good traction looking at ambulance conveyancing data from care homes, alarmingly high rates of conveyance in some cases. So we've got a few minutes left. The way the tech is working this morning is I can't see any of the questions. I think one of our team is able to see the questions. So if you haven't already, post your questions in the Q&A. As I say, I can't see anything. So Andrew, are you able to see any questions and see if we can answer them?
So I'm just coming into the questions. Is there a reason why the dashboard is split into 65 plus and 75 plus groups? I think I touched on that one slightly, but Adrian, I was wondering whether there is a reason why 75 is used so popularly in the NHS.
Well, I mean, that's a tricky, and that's why, you know, I said we put in a load of data and you have to make a judgment of it. I mean, what one is primarily interested is older persons living with frailty and the hospital practice, good or bad with that. So over 75s, you know, but this is changing. It may need to shift. Over 75s is at least a ready reckoner of likely to be frail, while 65 is too young. So broadly, it's that traditional ready reckoner that is used in a lot of analysis. But much more important, as both of us have emphasized, is then this cut by frailty, which is the over 65. It's not the over 65-year-old patients, it's patients living with moderate or severe frailty as identified by Simon Comrie's hospital frailty risk score. So that's the key trick here. And one of the things in the initial headliners is the proportion of your over 65-year-old admissions who have that moderate and severe frailty. So that's the thing. And I think, as we said, you know, rubbish coding equals you will under-identify frailty. So that's why for a few of the key metrics, we've included both. But primarily, I mean, obviously the interest, as Andrew elegantly pointed out with that last slide, it's frailty is this huge source of variation, but equally, as we see from my very first slide, variation between hospitals. So Andrew, do you want to add anything to the
No, there's a couple of questions that actually are on a similar theme. So one of them is around HFRS relies on ICD-10 codes can under capture frailty. Plus for deprived areas, especially under capture of frailty in the under 75s. In some areas, especially deprived, frailty prevalence of under 75s in acute hospital can be as high as 25 to 30%. What would the next phase of the SAMIT be in terms of this and potentially using the CFS? So I'll just pick that one up to start with. Absolutely, yes. I mean, the HFRS picks up patients under 65. The BCMI, which is the case mix index, actually uses frailty of all ages, of all adults. But you're right, once the CFS is in place and has settled down, then I'm sure that we would be looking to use the CFS in terms of the scoring. Adrian, do you want to add to that?
Just on that point, and as you say, this is a sort of headline look that has to be locally interpreted, but that was a really important point whoever made it, to say premature frailty early mortality is a feature of high levels of deprivation. And as we all know, England has huge area inequalities built within England. So there is the problem of identifying frailty in slightly younger patients, because they have the same risk for adverse outcome in hospital. But we go on the initial validation. Now, personal communication, as in I met Simon Conroy recently, it looks promising that the hospital frailty risk score works well in the under 65s. So we may be able to extend its use as a subset, but point taken at the moment, and that's why your hospitals, but in areas with very high deprivation, Merseyside, Teesside, etc., the demographic is so different from Surrey and Dorset and places like that.
Okay, there was a question about, will Welsh hospitals be able to compare within Wales and within the rest of the UK? Now, I'll pick that one up slightly, in so much that the SAMIT and the SAMIT 75 are not products that are in Wales at the moment. We've got the SEDIT in Wales, but we do quite a lot of due diligence of the data sets to ensure comparability between what England is recording and what Wales is recording. So I would like to think that it is possible to do that as and when Wales then picks up the SAMIT tool. Question for you. Oh, sorry.
Just on that, Andrew, I mean, I think we would welcome it. So talk to your government. For frailty, particularly, you note where SEDIT is in Northern Ireland, the integrated trust system in Northern Ireland is very different from England. So there may be some sense checking needed. But in principle, I'm a firm believer, get the data out there and let's have the discussion of what works and what doesn't work. And if anyone has influence on their government in Wales or Northern Ireland, talk to them. We'd be happy to explore that further. Andrew.
There was a question about the capacity section, essentially. And are there any metrics capturing staffing establishments and correlation to baseline staffing of non-clinical staff regarding AHPs? Do you want to just pick that one up in terms of
there's
staffing?
Briefly in the SAMIT, there's data, and the SEDIT, there is data on staffing. It's not perfect. And we're reliant on hospitals to return it. And Andrew, you or Darren may want to comment on that. The problem with frailty and geriatrics, if you look at the specialty of geriatrics, it ranges from some hospitals, it doesn't exist. They don't have it as an allocated or credit of a specialty within their bed returns, to others where the geriatrics amounts to several hundred beds. So fundamentally, that's why we focused on all specialties. Frailty is that we can't really look at capacity within the specialized system unless, Andrew, you think we can somehow, but that was the problem, is that geriatrics isn't defined in any consistent way, so we've ignored that capacity section. I don't know if you can tweak it in some way.
No, that was the case when we were looking at it in terms of how services were set up in terms of a bespoke geriatric service, or whether it was a subset of the acute medical service. But that's why we struggled with the capacity domain. There was a question that was talking about linking to community teams, population health, and in fact there's a few questions that are talking about some of the other elements in terms of UCR, virtual wards, a hospital at home, discharge. And yes, we are looking to try and develop the data sets that are available around all of those, and I would like to think that they would then form part of future iterations.
And Andrew, I would say, I mean, this is sort of essential, because if we just carry on business as usual, we're not going to double the hospital sector in 25 years. So we've got to be pretty serious about demand reduction. And I believe that can be done with higher value, higher quality, because hospitals are so negative for other persons. So we do need the data to do that, but it's partly a data quality issue. But we're very happy to explore that. And the virtual ward is one specific, which has reasonably good data now, I think. So, of course, someone has to give us a check for Andrew to do the development work, but that's a detail.
Just a quick one on population health data. We did also develop what we referred to as population on a page. It's not bespoke to elderly patients, but it does set out prevalence, risk factors through to use of ED, outpatients, non-elective admissions, and then mortality. So it is that it's based on model hospital at the moment. And you can then sort of see there's about 25 metrics in there that support analysis of a population to try and as a baseline for understanding how the hospital should set up.
I was going to say the same, Andrew. There is stuff on population health for older adults geriatrics in model hospital, so do have a look at that as well. I mean, we're presenting SAMIT 75 here. I think it is for an acute hospital by far the most functional tool, just because it's so up to date and so dynamic. But have a look, population health as well as geriatric medicine is there in model hospitals. So you need, and you know, if you're developing a system frailty dashboard, you need that other intelligence in there as well.
Yeah. There was a question about moving SDEC to ECDS. Now, I have to admit, I don't know what the current timetable is. Last time I looked, there were about 50 hospitals publishing their SDEC data within Type 5 ECDS. I believe a lot of the other sites are moving quite quickly now. But I don't know what the final deadline is for that. And again, we will then adapt both SAMIT and SAMIT 75 when that happens, in terms of adjusting some of the metrics. One of the things that I wanted to say earlier was around length of stay. And you will notice that we have a number of metrics that are a length of stay excluding 0 day. And what that's trying to do is remove that ambiguity around SDEC, so that we can just look at length of stay for those patients that needed an inpatient bed.
Now, I think we're down to the last minute. We'll collate the questions, and I will attempt with Andrew and Darren to answer any of your questions. And do just contact any of us if you have thoughts and ideas, or just other questions outside this meeting about SAMIT 75, because the message is we think it's a fantastic tool. It's you know, taken forward this agenda hugely, which in turn takes forward the agenda with the senior leadership in the NHS and at your hospitals. So do, if you're not already signed up, play around with it, use it, and give us some thoughts, comments and questions. Would be great to hear. But thank you so much for the considerable attendance here. Any last words from either Darren or Andrew?
No, only that frailty is the main game in town in terms of demands on the NHS, and it's a huge challenge. But what we're trying to do is develop ways of better understanding it.
Yeah, and of course, probably everyone in the audience would agree with that, but data convinces, and this is so important. So play around with the tool, give us some feedback, and if there's appetite for it, we may run future sessions on this as things develop. So, and thank you to Sophie and Michelle, who've been coordinating this in the background.